Good evening, everyone present here. I am Faraz from IGCP Group. Welcome each of you on today's panel discussion on breaking barriers, innovations, and strategies in HIV prevention and treatment. Before starting this session, let's dive into the description. In this panel discussion, we will enlighten on the latest innovation and strategies in HIV prevention and treatment. Despite significant advancement, HIV remains as a global health challenge. With millions affected worldwide, this session will delve into groundbreaking research, emerging treatments, and effective prevention strategies that are transforming the landscape of HIV. So, without further delay, let's welcome moderator for today's session. And the moderator for this panel discussion is Dr. Sumit Arora, sir. And let me share some of the achievement of sir. Is a highly experienced consultant physician with a remarkable career spanning 25 years. Professor of Medicine and HIV consultant at Army College of Medical Science and Base Hospital, Delhi, Kant, and consultant physician at Room Clinic, Gurgaon, and he is 16 publication index journals to his own credit. Awards, and he is President Gallantry Awards Sena Medal Gallantry for service in Kabul, Afghanistan. Letter of appreciation by President of Sri Lanka for medical aid given to Sri Lankan civilians post tsunami 2006, and VCOS commendation for providing medical aid in civilians in Sri Lanka post-tsunami 2006 as a part of Armed Forces medical team in Sri Lanka, and his area of interest is teaching undergraduate and PG students of medicine and general medicine, HIV, and infectious disease. Sir, welcome to the show, and stage is yours. You can proceed from here.
Thank you, Faraz, for the kind introduction, and thank you, IJCP, for giving me this opportunity to moderate this session with eminent speakers. I apologize for my uh, phone. My laptop gave up on me today, and I have to use my phone. It's a bit shaky, but without any delay, we will go ahead and introduce our speakers. Firstly, we have Dr. Gloria Alexander, who actually does not need any introduction in the field of HIV. Uh, she is a very well known HIV consultant and founder of Asha Foundation. Award as a number of publications. She's worked with WHO, and she's an eminent, not only an eminent HIV physician, but I personally have been listening to her talks and seen her in various conferences speaking as an expert speaker. I welcome you, ma'am, to this discussion, and thank you very much for joining us. And our next speaker is Dr. Amit Dravid. He is also a well-known HIV physician based in Pune. He is a chief consultant of HIV medicine and infectious diseases at Ruby Hall Clinic. He is a well-known HIV physician fan of having heard in various conferences and forums in HIV, and he's an expert in treating HIV/AIDS and complicated cases. Has had many publications, presentations, and handbooks on HIV practices to his credit. Welcome, Dr. Dravid. It's a
Hello, Dr.
pleasure to
Sumit.
have you on this.
Thank you.
Welcome.
Thank you, Dr. Sumit.
Lastly, we have Dr. Subhangi Parkar. She is a Dean and Professor, Vedanta Institute of Medical Sciences, and she's an eminent psychiatrist who's psychiatry. She's introduced a new method of social autophagy She is the first female de-escalation board in India, inaugurated by Sri Gokhale, Commissioner of Then Mumbai Mahanagarpalika. As Dean, she started free breakfast for residents, which I found was a very, very considerate and unique achievement because that's something we don't look into how our residents work and how chaotic their life gets. This shows us how she takes personal care of her students. She's got a number of awards and felicitations to her credit. She's been awarded with the DC Marfatia Indian Psychiatry Society National Award and many other awards on the screen. I welcome you, ma'am, for a full year. I welcome all the speakers, and without any delay, I would like to I'll start with Glory, ma'am. I'd like to start the discussion with how to provide HIV care to people in the community, especially to people, key populations who are underserved. There are a lot of patients who don't get good care due to various reasons in our society. The mainstream society still is taken care of by NACO and by private players, but underserved populations like MSM, transgender,
So,
to
good
ask
evening
ma'am
to
how
everybody. When we talk about underserved populations, we are talking about key populations. We are talking about gay people and men who have sex with other men. We are talking about people in sex work, both males and females. We are talking about people who inject drugs. We are talking about people who are uh, transgender, and we're talking about people who are incarcerated, like people in prison, etc. So these are people who are underserved, and the main problems that these people face are that they and also these key populations actually now contribute to a large percentage of new HIV infections that we see every year. So these people are actually have a lot of problems. They are faced with intense stigma and discrimination. They are faced with violence from the community. They are
ma'am,
faced with, can you hear me?
your voice is
You can't hear me? Hello?
Ma'am, we can hear you. We can hear you loud and clear.
Okay.
okay.
So
I'm not able to hear.
yeah, there are also people who are denied human rights, and there are people who are criminalized. So they have a lot of issues that they have to face besides just being living with HIV. So one of the methods by which we can help them is what we call a differentiated service delivery, where instead of having a top down approach, we have a bottoms up approach. So the client actually becomes the center of all our services, and it becomes a client centered model of treating a patient, rather than coming from top and telling the patient what to do. The second thing that we do with this is that it is key population led programming. That is, the key population themselves have very active roles to play in identifying and bringing people to this client centered model, and also being involved in the care and treatment of people, in identifying care and treatment of people who belong to these key populations. And then you have what is called a one shop stop, where all the services are provided at the same place, and the client doesn't have to go from one place to another for different parts of treatment. So if he can have self testing at the same place, he can have counseling at the same place, he can have treatment. If he needs prevention and he's not positive but at high risk, he can have treatment at the same preventive treatment at the same place. He can be treated for, his mental health issues, for sexually transmitted diseases. So it's like a single shop where, or one single window for all treatment that he receives. So those are the kind of new approaches that we use to handle people, to provide equitable access to people who are belonging to the key populations. Also, online services, self-testing, where you can, where the patient can test himself and therefore doesn't feel shy to come out and get tested, and with help from counselors and other healthcare providers. And they can do their own testing, and if it happens to be positive, then of course they come to this client-centered center where they receive treatment. The other thing that we can do is, it's basically a personalized approach, so where they are not faced with much stigma and discrimination. The very other important thing is that all healthcare providers need to be sensitized about key populations, because we are one of the communities who are quite stigmatizing and discriminating to people who belong to the key populations. So I think if we do this differentiated service delivery and involve the communities and provide a single window for all the treatment, that would be the kind of equitable access that we can provide to these underserved populations.
Right, ma'am. So, we can give them services at a single place, I think that's a wonderful thing. And I'd like to ask Dr. Shubhangi, ma'am, regarding stigma. Do you see that stigma reducing in the last years or a decade in HIV, or you feel that it is still a problem? Do you still see patients referred to you? Hello? I can't hear Dr. Shubhangi.
There is, yes, there is still stigma associated with HIV related status, whether it is a new or whether it is a chronic patient. And remember that stigma means something which is negative perceived by the people around. It's not just the negative pursued by the people around. There is also internalized stigma among HIV patient refers to the acceptance and incorporation of negative societal beliefs about HIV, the discrimination system, the loss of opportunities, the one's self concept probably is causing a lot of humiliation, and it profoundly affects psychological health. By lower self esteem and shame, patient may internalize negative beliefs about HIV, leading to feeling of shame, guilt, and diminished self worth. There is a social withdrawal. Now, these people, there is external stigma from people, but internalized stigma is much more trouble of late. There is a fear of rejection or discrimination that can lead to social isolation and reluctance to disclose their HIV status, impacting lot of social support or the relative supports or the friend support. There is a huge psychological distress associated with the stigma because it contributes to higher level of anxiety, depression, and stress, generally leading to exacerbation of existing mental health challenges. And generally these these are associated with HIV patients. There is a lot of hatred, or there is a lot of helplessness, there is a lot of worthlessness, and there is a challenge to identity crisis. People have to really navigate their personality in terms of what people say, in terms of what they have to cope up with the illness, sufferings, the treatment system. And there is re-evaluation of their life. There is issues related to relationship, especially in the key relationship like marital relationship. There is a huge anger and frustration because they can't express. Internalized stigma make people so isolated, and there is no opportunity to ventilate out. So some patient may feel angry or frustrated about their diagnosis, questioning why it happened to them, and struggling with the feeling of unfairness. And this is all, which is very important, leads to treatment non-adherence. People generally do not go to the treatment procedure, and they keep themselves away. So with the stigma and with mental health issues, most of these people suffer more, and their conditions, medical conditions, start getting deteriorated. Yes.
The problem you deal with in HIV patient and mental health? The commonest reason for referral to a psychiatrist, Dr. Shubhangi?
Yes, yes. A commonest reason for referral to psychiatrists very often is common mental disorders that are associated with HIV, and besides, their non-adherence to the treatment. Pretty often it comes. There is relational issues, that also a major problem, and the fear of being stigmatized or discrimination against can cause significant distress. And most of these patients, they go through this. There is a lot of guilt and shame also. Some individuals may feel guilty or ashamed, especially if they believe they contracted the virus through behavior they regret, or think others might judge harshly. Now this is where we really have to be sensitive. I mean, we just can't label that patient has depression, has anxiety. We really understand their perceived ideas about having HIV, how they suffer. So this is a very important perspective. It's not just psychiatric treatment, but it is also a very skilled counseling, or sometimes, like I am trained in cognitive behavior therapy, so very often I use those kind of therapies to deal with their irrational beliefs, their self-pitying beliefs. And that is how we really have to be very, very sensitive, very proactive in dealing with HIV patients with mental health issues, and most of them have this.
Moving to Dr. Dravid. Dr. Dravid, I'd like to ask you about the innovative therapy not available in India, but long-acting injectable ARTs. Do you feel that they will be a blessing?
Yeah. So, thank you, Dr. Sumit. See, the question now is that why do we need further therapies? If you look at the treatments available today, the commonest treatment prescribed in the government sector and the private sector today is a single pill of tenofovir, lamivudine, dolutegravir. Since it has come into India, it has revolutionized HIV treatment. If you look at the suppression rates on tenofovir, lamivudine, dolutegravir, they are in high 95%. So you can blankly tell a person who is HIV positive, who is starting antiretroviral therapy today, that if you take more than 95% of your pills, it is impossible for you to be virologically failing. And we have had patients now who are on decades of treatment. So today we are actually telling patients that your lifespan will increase in decades. In the US, there is a very famous graphic which tells patients that if you are 20-year-old today and you are on treatment, then you will survive for 4 to 5 more decades. So we are actually telling our patients that you are going to age into your 60s and 70s, and nothing is going to happen provided you keep on taking your pills. But the problem with keeping on taking pills is what is called as pill fatigue. Our patients are getting older. In addition to HIV, they are now having problems of diabetes, obesity, liver disease, kidney disease, bone fragility, and all this entails polypharmacy. And as you know, every person who is above 60 years of age in India today has a problem with polypharmacy. So there are just too many pills which the patients have to take on. It leads to pill fatigue. And when we talk to patients in our OPDs, patients tell us that when is this going to end? Are we ever going to get free of our pills? And every time I remove my pill, I remember that I have HIV in my blood.
Wow.
Every time I go to
Absolutely.
a function, a social function, I have to just check my watch whether it is now time to take my pills. If I am with my relatives, I suddenly can't get up, go take my pills, and come back. So these are real issues which our patients are suffering from. They are just tired of taking pills every day. They are just tired of hiding their disease from their relatives every day. And they say that, is there anything more comfortable which is available? So the answer is yes. In 2020, Canada was the first country which gave approval to an injectable regimen, an injectable two-drug regimen, which was of cabotegravir, which is an integrase inhibitor, which is a sister drug of dolutegravir, and rilpivirine, which is a NNRTI, which is a sister drug of nevirapine. They combined these two into a single injection, and when given IM intramuscular, they found that in those patients who are suppressed on first line antiretroviral therapy, shifting these guys to a two drug injectable regimen actually maintained the virologic suppression and maintained the virologic suppression for almost 3 years. So long term data is now available. In 2020, Canada gave in principle approval for patients who are virologically suppressed to be shifted to this two drug regimen. In 2021, US gave the approval to, to its patients, and in late 2021, even Europe started shifting majority of its patients. So now there is a move in the Western world towards shifting to injectable regimens, injectable two drug regimens, and you can see that actually you can tell your patients that if you are suppressed on first line antiretroviral therapy today, I am shifting you to an injection which you have to take IM once every 2 months. So, in fact, your treatment is simplified to 6 injections a year rather than 365 tablets a year. So, you just have to remember 6 dates, provided your hepatitis B negative, because neither cabotegravir nor rilpivirine acts on hepatitis B. If you are just HIV mono infected, shifting you and you're on first line, you have never failed earlier. Shifting you to cabotegravir rilpivirine first is convenient, it improves adherence, and now more and more studies are coming in that if you have patients who have, if you know that they will have problem with adherence, there are patients who are addicted to alcohol, there are patients who are addicted to IV drug therapy, there are patients who are homeless, there are patients who are prisoners. All these patients, you know that even if you start very good antiretroviral therapy, there is a high chance they might not take these drugs regularly. So even for these guys, these injections are now a blessing in disguise. So I envisage that once injectable antiretroviral therapy is introduced in India, and provided it becomes available through the public sector and becomes very cheap in the private sector, majority of our patients, almost 95% of them, are HIV mono infected. They are on first line antiretroviral therapy, they are suppressed. So there is a huge market in which we can shift these patients and we can actually tell them that you might not become disease free, but you definitely will become pill free. And that is one thing which many people are looking forward to, and I think it will be a huge innovation and a huge step forward in management of HIV care.
But it's still not a standard of care even in the West where it's been approved and is available. Why is
It's
it
not.
so?
It
The
is
first line is
approved.
still a three drug
Yeah,
combination,
yeah.
oral.
It is only approved as a therapy for patients who are suppressed, because all the
Yeah.
trials for cabotegravir rilpivirine were done in patients who were suppressed, because they were worried that if the patient start failing on this regimen, if once we give it upfront, and if you are failing and you are giving a depot preparation which is going to be there in your body for a very long time, say 2 months, then the chance of picking up resistance is also higher. So they reserved this drug only for patients who were suppressed on first line antiretroviral therapy. So injectable regimen is there only for people who are suppressed on first line antiretroviral therapy. But if you look at the Indian data, almost 90% of our patients are on first line antiretroviral therapy, and out of that, almost 80 to 85% are suppressed. So there is a huge population in India also, which is suppressed on first line antiretroviral therapy, which can actually go on to injectable regimen. That's why it is an alternate regimen, can be used only if you are suppressed on first line antiretroviral.
But the fact that we are not doing genotypic drug resistance testing as widely as in fact, hardly done compared to the West,
Yeah,
isn't that a detriment?
yeah.
And
So this is
the fact that compliance is never guaranteed in our patients, and they may be harboring NNRTI resistance, first line NNRTI resistance, which might compromise rilpivirine. All those issues.
Yeah. So this was the precise question which was answered by a trial which was known as the CARES trial, CARES, which was published in CROI 2024, just 3 months back. So this was the precise question which they answered, that you are saying that in Europe, in America, in Canada, this injectable regimen is doing very well, but majority of the patients are there in the resource limited setting. There they don't do viral load every 6 monthly as is done in the West. There they have a lot of NNRTI resistance as is not there in the West, and many times the follow-ups are not on time. So what happens to these patients? So what they did was, they took an African population which is very very similar to our free ART setting in India, and they enrolled almost 500 patients into this injectable regimen. What they did was, if you are in on a public sector first line antiretroviral therapy in Africa, that is the TLD regimen, once you are suppressed and you are HbSAg negative, they shifted them to cabotegravir rilpivirine and gave them every 2 monthly injectable regimens. What they found was that despite doing viral load only once a year, despite having a very high NNRTI resistance at baseline, which was almost 10%, which was supposed to knock off even rilpivirine, which is an NNRTI, still 95% of patients who were shifted to cabotegravir rilpivirine were suppressed at 1 year. So this trial actually came as a boost for the free ART sector, which said that even if you don't do viral load every 6 monthly, even if you have baseline NNRTI resistance, if your patients are on first line ART and they have never been failed before, shifting to cabotegravir rilpivirine works in resource limited settings as well. So that was the boost and shot in the arm which the free ART sector was looking at. And now with this trial being published, it will be published in Lancet soon. Hopefully now even the government starts thinking proactively about shifting majority of their patients to injectable regimens, because it is convenient for the government sector as well. Just call them once every 2 months, give them injections. You don't need to make them stand in line for every 15 days, every 1 month, every 3 months, whatever is your plan, and do viral load just yearly, and still the patients will be suppressed. So this is actually a boon for the resource limited setting as well. Although we have baseline NNRTI
Yeah, the
resistance touching
crowding of the
10%,
narco centers will go.
yes, the crowding will reduce, and the patients will be happy that they don't have to carry these pills back home, which will, sometimes disclose their status to all and sundry, which can be a big part of the stigma which they face.
Yeah. Lot of our patients don't want to go to narco centers because of this overcrowding.
Precisely.
So if it is just once a 2 month visit for an injection, it will be much easier. Okay, we'll
And
come back.
provided if they can, yeah, just a short comment. If even
For
this injection
yeah, yeah,
yeah, just if this injection becomes easy to take, just like an insulin injection where the patient can self administer it at home, it will be even better. So you don't even need to call them every 2 months, you can call them every 6 months and ask them, take these three injections at home and you'll be fine.
Let
Even that can be tried.
Okay, okay, fine. Dravid said that the present ART regime is excellent and virological suppression is great. People are living longer, and even the concept of U is to U, we've made quite a lot of advances in treatment of HIV. Patients are living much longer. Little far from a absolute cure. Uh, when is it around the corner? A lot of my patients, they constantly keep that, like, stigma is there. So in spite of being healthy for decades, my patients still come and ask me for decades.
Are you asking me this question? Because I can't hear
So a
you
cure or
very
a
well.
sterilizing
I
cure.
can't hear the moderator very well. Okay. Uh, so when we look at cure, we are looking at two aspects of cure. One is the functional cure, and one is the sterilizing cure. Can you hear me?
Yes, ma'am.
Yes,
Yes.
yes.
Okay. So when we look at functional cure, we actually mean that the patient still has virus in the body, but it is controlled, and the patient is well controlled even without treatment. So that's what we mean when we say functional cure. When we say sterilizing cure, we actually mean elimination of the provirus itself from the body, and the patient doesn't have any virus. So these are the two cures that we are talking about. With regard to functional cure, as all of you know, we have many instances of cases where patients who have been living with HIV and who happen to also simultaneously have um, either a leukemia or a lymphoma and had to undergo either bone marrow or stem cell transplants as a treatment for their secondary problem, actually also recovered from HIV. This is because they received a delta 32 free type of stem cell transplant, which prevented the HIV from entering the CD4 cells, and therefore patients were cured of HIV in the sense that they did not require treatment after the stem cell transplant was done. For a few years, they took HIV treatment and then they recovered from it. So there are about 4 or 5 patients living now who um, are not on treatment and who have got a functional cure. Then we also talk about a patient from, the Argentina lady who was on treatment from 1996 till 2007. She was on various regimes of ART. She always had side effects with all these drugs. Then finally, 2007, out of frustration, she stopped the treatment. And in spite of it, her viral load is not detectable and she is living well even without treatment. She probably is a post treatment elite controller. And then we have the Visconti study where we have several people who have been on treatment, which has now been stopped and which um, shows that they continue to live without, at least I think there are 27 or so of them who have received treatment and then stopped treatment. And yet, uh, for more than 10, 10 and a half, 11 years, and yet they are doing well and their viral loads are not detectable. So these are some of the reasons, I mean, the functional cure patients that we're talking about, but this is not something that can be used for across the board for all patients living with HIV. With regard to sterilizing cure, there are several reasons. One is because of the genetic diversity of the virus itself, its variability, because of the fact that it mutates every 24 hours and produces new mutations, which are difficult sometimes and which give rise to resistance. And then you have the latent reservoirs, which are sitting there in the lymph nodes and other parts of the body, which, when you stop treatment, these latent reservoirs become active and come back into the blood, and then the patient gets infected again. And then, so for all these reasons, we don't really have a sterilizing cure at present for HIV. We are also talking about the broadly neutralizing antibodies, which were detected from people, elite controllers produced from them, which have a broad sense of neutrality, antibodies towards treatment. All of these treatments and research is still going on. But currently, we cannot say that there is a definite treatment for people living with HIV in terms of cure. The other thing that we have to remember is that because of the treatment that has been happening over the years and how this treatment has become much better compared to before, we have less side effects. It all translates to taking only one single pill every day, once a day for the rest of your life, or like he said, uh, uh, 6 injections a year, or maybe even 2 injections a year if injection subcutaneous lenacapavir comes into the picture. So the treatment today, we can look at HIV as no longer as a life-threatening acute as a fatal life-threatening illness. We look at it as a chronic manageable illness, just like diabetes or high blood pressure. But it is the patient. So in a way, all these patients are doing well. We have patients who are living for decades with HIV. We have got little children who've grown up into adults, who've got married, who've got HIV negative children. We've got HIV positive people marrying HIV negative people and living good lives because of U is equal to U. So all of this progress has happened. And today we are saying that a person living with HIV has a normal lifespan as compared to a person who's not living with HIV. And yet we have patients coming to us and asking about cure. And this is probably a lot to do with the fact that there's a lot of self stigma in there. And the world doesn't need to know that they are positive. They just live with it, and nobody else around them knows. In many cases, it's only the husband and wife who know that they are positive in a family. Extended family doesn't know. And yet there is so much of enthusiasm for a cure, and somehow a permanent cure for HIV has still not come into the picture. We hope it will come in the future, but right now it's still not there. And we can only talk about functional cures and sterilizing cures for HIV.
Yes, ma'am. Thank you. You mentioned elite controllers, ma'am. Just a quick word on your opinion on treatment of elite controllers. Should we treat all? Should we follow up? The protocol is to treat, but
Yes, it's a controversial question, and but the protocol is that even if the patient is an elite controller, you need to treat that patient because you have this chronic inflammation, which is a condition that most people living with HIV have. And even if they have a very small detectable viral load of 200 copies, 300 copies, even though they will not transmit the infection to another person, they can undergo chronic inflammation. And it's a chronic inflammation which gives rise to the heart disease that you get in people living with HIV, to cancer, to strokes. All of this is because of the chronic inflammation secondary to the HIV infection itself that exists. So, as per protocol, you have to treat people, even elite controllers. I talk to each person, their age. I look at various factors before we make that decision. And it's a decision that has to be made by the doctor and the patient because, when you're putting the patient on this treatment, it's lifelong. You can't play around with that.
yes,
So it's a discussion and you have to take it on an individual case basis and make a decision. But the protocol says treat everybody, even if they are elite controllers.
but in your opinion, we can individualize the treatment as per patient.
There because I am individualizing and looking at each patient. Now, if I have an older patient who's an elite controller, I would definitely put that patient on treatment. For the younger patients, I watch them. I do their CD4 counts every 6 months. I do their viral loads every year. If there's any indication that I need to put this patient, if the patient has a comorbidity, I immediately start. But yes, I individualize the treatment.
Right, right. My next question is for Dr. Shubhangi. Like ma'am mentioned that there is a lot of self stigma among patients. Uh, they themselves feel stigmatized where maybe externally the stigma is not obvious. And how does internalized stigma affect the psychological health of HIV patients?
Yeah, that's a very good question basically because internalized stigma is I am feeling bad about having HIV than what people feel. right? And this is something which probably leads to demoralization of the person, because see, the external stigma is something which people attribute, and maybe you need to cope up with it, but something which is internally comes out. So what is that? It is something about one's self concept. It is something about one's own identity crisis, that how are you going to deal with people than people dealing with you. Okay, so there is a lower self-esteem and shame. Patient may internalize negative beliefs about HIV, leading to a feeling of shame, guilt, and diminished self-worth. So generally will remain demoralized continuously. There is a social withdrawal, fear of rejection or discrimination that can lead to social isolation and reluctance to disclose their HIV status, impacting the social support network, and even reducing the interactive approach. Developing good network also is impossible for these people. There is a psychological distress in terms of higher level of anxiety, depression, and stress, exacerbating existing mental health challenges. So this is something which probably heightens the level of mental health issues, and increases the occurrence of it also. See, there are two issues which are very important with mental health. Acquisition of HIV is more because of the associated behavior, because of the loss of judgment, and sometimes the disinhibited behavior, and also with serious mental illness or with common mental disorder, people can see lot of HIV issues. I have seen this. We had the center of excellence for drug addiction treatment, and there we have seen a lot many patients, even injectable behavior, where in spite of training, community awareness, because of the drug, they were losing their judgment. Because of that, the social judgment and the whole concept of caring for the self, protecting oneself from the dangerous behavior was not possible for the people. So having mental health issues is a very important aspect in dealing with HIV. So I think, as the doctor said previously, there are very good medications which are coming, but something which needs to be integrated always is with mental health. It is ultimately a matter of behavior control. So HIV a lot related to behavior control, and one's reaction to the HIV, one's well-being, one's quality of life, everything will improve if the people have positive aspect, or if their depression, their anxiety, or their adjustment disorders are treated well, so that they probably focus on their well-being. And that's the reason where mental health play a very crucial, very critical role in HIV. Yes, Dr. Arora, I completed. Yeah,
Yeah, yeah, Mom, my signal I think is not
yeah.
very good. I missed the last part. Am I Mom? Am I audible?
Yeah, yeah.
Yes,
My
yes.
next,
On and off.
I'd like to ask you about preventive aspects of HIV. Decide which patients to should go on PrEP? What are the kind of patients that come to you and say that can be used?
The question is for me.
Yeah.
So, First we need to
to put
understand.
on PrEP.
Yeah.
Yeah.
Yeah. So first we need to understand that PrEP is always to be given for a person who is per se HIV negative, and he is at a very high risk of contracting HIV infection. That is what the physician has to assess first, whether he is HIV negative at baseline and whether he is at a very high risk of acquiring HIV in the next 6 to 12 months. So which is this class of population? Number one is men who have sex with men, and especially those population where they are engaging in sexual intercourse with multiple partners, multiple unknown partners, and many times without condoms. So that is one thing we need to ask. Second population is transgender, cisgender, women and men, because they are also subjected to multiple sexual encounters with multiple partners and many times without condoms. Thirdly, IV drug abusers. If a person is a compulsive IV drug abuser, he is giving you history that he shares needles with his friends. The HIV status of the friends is not known. Then these are the first group of patients who actually need PrEP. In India, especially, these are the ones. Then there is a second group where uh, serodiscordant couples, where the wife is negative, the husband is positive, and she cannot convince her husband to have protected sexual intercourse with her because of maybe the risk of abuse or risk of trauma. That is one thing. Then there are prostitutes or commercial sex workers who are also at high risk of acquiring HIV infection. Today they are HIV negative. Maybe they can turn HIV positive in the future. So this is a second group which can need PrEP in the future. There are three drugs which are applicable for PrEP. Number one, the two are oral regimens. One is an injectable regimen. The two regimens are an oral regimen of tenofovir emtricitabine. Second is an oral regimen of tenofovir alifenamide fumarate and emtricitabine. And third is an injectable regimen which is cabotegravir. Out of these, the first two oral regimens are available in India. They can be started, but remember that once you start the regimen, we have to ensure that the adherence to the regimen is top notch, because if you acquire incident HIV while on PrEP, the main reason for acquiring incident HIV while being on PrEP is non adherence to the regimen. So all those patients who took PrEP at least between 4 to 6 doses every week were associated with lower risk of acquiring incident HIV. But even there, the chance of incident HIV is there. And hence, there was a study which was published in the NEJM, which showed that when you give injectable cabotegravir, that is 600 milligram of cabotegravir once every 2 months, as compared to taking daily oral PrEP of tenofovir emtricitabine, the risk of getting incident HIV among gay men and cisgender women was lower, almost 78% lower in injectable cabotegravir regimen as compared to the oral tenofovir FTC regimen. Why was that? Because the adherence was highest when you give injectable regimens. Here you don't need to worry about taking oral tablets every day. You just have to take one injection every 2 months and not worry when you are going to have risky sexual intercourse. While in oral PrEP, you have to really think that every day you have to keep taking this tablet. So for HIV negative population, to keep taking a tablet regularly, just like an HIV positive population, sometimes can be very distressing. And then they start taking
Yeah.
on demand. That is, when they have sexual intercourse, they take it for 7 days, then they stop. That is not the right way to go. That's actually a risky way. And there is a very high risk of acquiring incident HIV if you keep on doing on
But
demand PrEP.
if
Yeah.
taken properly in the MSM group, is it not an accepted way? Only in MSM.
Yeah, it is an accepted way but not the ideal way. So if you look at the ideal way where you want the least number of infections, then the thing is to take it
Yeah.
daily. It outscores over on demand PrEP. And remember that on demand PrEP is very difficult to convince people. If it's easy to take, but then it
Yeah.
can have high failure rates. So the ideal is to take on demand, is to take daily PrEP. But many people get exhausted because they feel I am HIV negative. Why am I supposed to take tablets just because I am at high risk of uh, uh, contracting HIV because of sexual intercourse? and many times they stop it. So when studies were done to see why the PrEP failed, they found that the drug levels in blood were the lowest in patients who actually acquired incident HIV, and only 75% of patients even in clinical trials ended up taking daily PrEP. So you can see if in clinical trials the patients, only 75% of patients are actually adhering to PrEP, in real world it will be even lower. The adherence is somewhere
Yeah.
between 40 to 50%, and that is the reason why injectable regimens are now scoring almost 78% higher than oral PrEP regimens, and they are the future. In fact, WHO has put out an advisory saying all countries who can afford injectable cabotegravir as a PrEP regimen should be considering to roll it out in their ART population as well. So this is what it is coming. So just like we are moving towards two drug injectable therapy in first line as a maintenance regimen, we might be moving in the future from oral tenofovir emtricitabine daily PrEP to injectable cabotegravir once in 2 monthly PrEP, which will score much higher
Do,
than oral PrEP.
do you see that coming into the national program at any time in the near future?
It all depends on whether it is produced in India, which is definitely it is going to be produced in India. What I hear from is four companies have got licenses to manufacture cabotegravir and cabotegravir rilpivirine, and finally it will be the cost. In India, everything is governed by cost because we are a low and middle income country. If the cost is low enough, definitely the government can think of purchasing it and giving it free in the free ART sector as an injectable PrEP. So everything will depend upon local production and the cost of rollout of therapy. But as you see in India, once it is starting to getting manufactured on a mass scale, the prices drop precipitously, and India manufactures for the world. So I am pretty positive that injectable first line antiretroviral regimens and injectable PrEP regimens will be a reality not far from now, maybe 2 years from now, in India as well.
In the private sector?
Private and free RT sector as well, because there will be immense pressure on the government to roll it out in the free RT sector as well, because that will be the global norm by them.
Okay. So, but don't you think following up these patients and keeping them on PrEP is a challenge? Even with injectable, following up and
Absolutely.
maintaining adherence, because the risk of long-term injectables not being taken regularly or being missed also leads to the risk of integrase inhibitor resistance development. So
Absolutely.
in
It's
our
a
country,
very
where follow-up and assuring adherence is a challenge.
Yeah, absolutely, a very fair point. These There were studies done in Africa where they ended up giving injectable PrEP, and they found that only 44% people followed up at 1 year. So the one thing is the same, that if I am HIV negative, why am I supposed to take something just to prevent HIV? So
Yeah.
that seriousness doesn't creep into. But yes, that is where counseling, that is where psychological counseling, that is where local follow-up, that is where community health worker engagement with the patient comes into being. Because as you rightly said, if you take your injectable PrEP irregularly, then cabotegravir resistance will develop. Not just that, cabotegravir resistance will develop, it will develop cross resistance to dolutegravir. So if you have incident HIV on cabotegravir injectable, then you might be thinking that even integrase inhibitors, dolutegravir might not work,
Yeah.
or will have to be given in a
Yeah.
higher dose. So it is a concern, but the numbers which actually develop incident HIV on cabotegravir taken regularly is very low. But
Very
if
low.
you develop incident HIV on cabotegravir, it's quite likely that it will be cross resistant to dolutegravir as well. So that is a reality, and that is what WHO and the world is concerned about. But maybe we will have more data as more and more patients go on it.
Uh, my next question is for Dr. Glory, ma'am. Continuing from here, ma'am, how do you see implementation of HIV prevention programs? How is there any way of expanding this program in our country? How do we prioritize this? How do we any innovative way of optimizing coverage for HIV prevention? There are many aspects to HIV prevention, PrEP being just one, but an integrated approach taking
So
this
when you
challenge.
look at prevention, there are basically three groups of people in which prevention is required. That is, men who have sex with men, women in sex work, and uh, drug use, injecting drug use. So these are the three groups really where we give, and in zero discordant couples also.
Yes.
But now with the concept of U is equal to U, where we have a husband wife couple where the husband is positive and the wife is negative. If the husband is on treatment and he becomes undetectable, then the risk of him transmitting HIV to his uh, spouse or his partner is zero if his viral load is undetectable. So that is the beauty of U is equal to U. So when we look at zero discordant couples, prevention that way really has no role to play, though we continue to say please use the condom. And it's only if they are interested in having a child, then we looked at the context of, at the context of unprotected sexual contact during the ovulation period. And we also cover the wife with PrEP during that period. But otherwise, PrEP is for these three main groups of people where they are, as Dr. Dravid very rightly said, they have to be HIV negative and they have to be at risk of acquiring HIV. So it hasn't really taken off in India, if you see PrEP. Because first of
Yes,
all,
ma'am.
when we look at the key populations, it's most useful in the key populations, and the key populations are really hidden in our country. They're not coming out among themselves by word of mouth through their social websites. They may be using PrEP, but that's a big
Yes, ma'am.
mistake because they don't have any professional advice when they do that.
Yeah.
But that is possibly happening. PrEP guidelines actually came out in 2012, but it's not being actively followed in India. ICMR is doing a big project on PrEP. I think somebody with S, Seema Sahe. Dr. Seema Sahe is doing a lot of work with PrEP research. But on the whole, and then there are studies across the world which have shown that people prefer injectables to orals for PrEP. There have been many
Yes.
studies, and main thing is the stigma. When they're seen taking a pill every day, relatives, everybody will ask. But injections, the good thing is that nobody knows. You just go quietly, take your injection, that too once in 2 months. But it has all its other effects that Dr. Dravid brought it out so well. So at the moment in India, PrEP is not moving in a very big way because of the communities that have to take it and the hidden communities and their access, the equitable access that they should get, that is not there. In zero discordant couples, it's a different picture altogether. So yeah, it is not moving at a great pace, not like it is in the rest of the world, where everybody is talking about PrEP and its use. In India, somehow it's a little more subdued.
Any suggestions, any ideas, ma'am, how we can implement PrEP in these key population?
So I think the first and foremost is what I said in reply to my first question: how do you provide? So it's a whole set of policies. It is multi-stakeholder level. It's not just healthcare providers. First of all, laws have to be modified which favor key populations. Violence
Yeah,
against key populations
decriminalizing.
has to reduce. Criminalization has to disappear. All of that has to happen. Then only will they come into a public forum where they know that the healthcare providers have been sensitized and they can take PrEP without being discriminated against. So there's a whole bunch of things. I don't know if you are aware of the 10%, 10 is to 10 is to 10 that UNAIDS has come up with, that by
Yes, ma'am.
2025, less than 10% of the countries, that is 90% of the countries should have a policy on key populations. 90% of countries should have a policy on gender-based violence and women and discrimination towards women. All these policies are there on paper, but unless they are translated into action on the ground and the atmosphere is created which makes it comfortable for people to take PrEP from the key populations, it is a big difficulty. And it has to be worked at multiple levels: government level, stakeholder level, people who make the rules, the actual workers, the key population themselves. One thing that works is involving key population, empowering key populations, and they go and work with their peers and try to improve the situation. There are several studies which have shown that key population involvement is crucial to provide access to treatment, care, and prevention.
My network is a bit shaky. I
Yes.
think, uh, so sorry for that. But I think we were running. Uh, any last comments, Dr. Shubhangi? I'll ask you one more question. A problem I face in my practice where patients refuse to go to a psychiatrist, which is a very specialist for cross referral, because they don't want to be identified. So I end up starting SSRIs for a lot of my patients for depression. Can you tell me important pointers where we should always refer the patient to a psychiatrist, where it is a must in our HIV population, dealing with a lot of anxiety, depression?
Madam, you're on mute. We can't hear you, madam.
Yeah.
Uh,
Even I couldn't hear her, but I thought my network is
Yeah,
bad.
I'm glad that research is increasing. There are good medications and there are good choices for the people. But somehow, in spite of having everything outside, if I am not able to look into my own well being, if I don't pursue my quality of life, I think nobody would take interest in anything which does good to oneself. And that is exactly very clear in terms of kind of HIV kind of illnesses. Now, people generally are negative and, labeling psychiatrists, where psychiatry still is being taken as a non-biological, which is so much biological. For even in the HIV, it affects brain. Some drugs affects brain, and that leads to depression. We must know that. So I think we really need awareness, and we really need to see that it is not the control of the HIV as a medical aspect. It is also the inner control of a person, to have the motivation to get well, to improve the good quality of life, which is very important. I'm a yoga practitioner. I'm also practice meditation, and I think we really need to get integrate what India is giving to people, so that they have a good control on their mind. They become cooperative to their medication, and the calm mind, probably will help in their immunity. So yoga, meditation, spirituality also should be utilized, that can play significant role in the well-being of the HIV patient, will lead to stress reduction, improved mental health, enhanced quality of life, supportive adherence to treatment, and community and support. I think these are all important issues. And when you talk about SSRI, remember one thing: the depression, common mental disorder, they are all treatable. Okay, and that's where we really need to promote these patients, because depression is dangerous. If you have depression, you will not even take treatment properly for your hypertension, for your diabetes, and hence treating mental illnesses when they are associated with other major illnesses as a comorbid condition, we must treat those, so that patient or the client will become more positive towards their treatment. Yeah, well, I mean, there is mind body connection for all this, and these practices must promote awareness of the mind body connection, encouraging patients to listen to their bodies, to listen to their struggles, and take proactive steps in managing their health, and especially the problems like HIV, which are still challenging issues.
Right. Thank you so much, ma'am. it's nice to end the talk on advice on mental health and spiritual aspects of life. We are running short of time, so I'll thank all our speakers, Dr. Glory Alexander, Dr. Amit, and Dr. Shubhangi, for such a wonderful discussion. And we hope to take positive points from this discussion and implement it in our practice in preventing as well as treating HIV, prevention being very important. And I am sure the future is very bright for our patients. We are coming up with newer therapies, injectables, and thank you all for this productive session. Thank you.
Thank you
Thank
so
you.
much.
Thank you
Thank
so
you.
much. Good day.
Thank you so much,
I'll hand
everyone,
over
for
to
joining.
Faraz.
Yes, sir. Thank
Any
you so
closing
much,
comments from your
everyone.
side?
Yes, sir. It was a really much needed session, as we know that like what is happening around our country, Tripura, and I hope that this session will be really much impactful to all the patients, all the population who are going from this problem. And thank you all the doctors to coming up with and taking out your important time to create a awareness among the society. Thank you so much once again. Until then, take care of yourself. We will back with some another episode with another topic with you all. Thank you so much once again. Good
Thank
night.
you.
Thank you. Good night. Bye bye.
Thank
Bye.
you.
And